Hi, I'm Debbie Levine. I'm the Senior Deputy Editor for Radiology, and I'm here doing a podcast with Dr. Glenn Lowe, who's a radiologist at Sir Charles Gardner Hospital in Western Australia. The title of his paper is Evaluation of the Utility of Screening Mammography for High-Risk Women Undergoing Screening Breast MRI. This is going to be published in the October issue of Radiology. And I'd like to mention that the study was actually performed when Dr. Lowe was in Toronto, Canada at the University Health Network, Mount Sinai Hospital and Women's College Hospital. Sitting next to me, I also have Dr. David Ballard, who is our Olmsted Editorial Fellow. He's here with us this week, and he'll be asking some questions as well. So Dr. Lowe, Dr. Ballard, welcome to the podcast.
Hello.
So Dr. Lowe, can you tell us a bit about your project and what you did and what you found?
Yeah, sure. So when I was a fellow in Canada, we reviewed our high-risk breast MRI screening program. I think it was 2012, 2013, 2 years consecutive. And these were a mixed population of women at high risk for breast cancer who were being screened with screening MRI, as well as screening mammography. And our question was, did the screening mammography add anything to the screening MRI? So basically, we retrospectively reviewed the data from our prospective screening program, which included a mixture of women who had the BRCA mutation, a high-risk family history with a high estimated lifetime risk, previous history of breast or ovarian cancer, or a history of natural radiation. And basically, of all the studies that were done and the cancers that were diagnosed in the group, we found that there were 45 cancers, 43 of them were seen on MRI, and 14 were seen with both MRI and mammography, but mammography didn't see or detect a cancer that MRI hadn't seen. So the two cancers that were sort of missed were missed by both modalities. So if we were thinking of having two screening tests, mammography and MRI, the mammography didn't add anything to just having the MRI.
Excellent. I have to ask, with only 45 cancers total, even though you had a very large screening population, but was your study adequately powered to make strong policy statements like you might not need mammography in these high-risk women if you're having MRI?
Yeah, I think that's a pretty bold conclusion that we did come to, and we did suggest that further studies and I think other institutions need to audit their data as well to confirm if you know this is going to be something that before a policy decision is made. So policy decision is a big decision. So no, I don't think that it's going to be powered. We only had I think 1,249 women included in the end, and yeah, that wasn't a huge number of cancers, but I think as a preliminary result, it's something that warrants further investigation.
Can you comment on the economics of using MR as a primary imaging screening modality in these high-risk women, such as the incremental cost-benefit ratio?
So obviously screening MRI is a very expensive test in terms of the cost of the examination, but also the time it takes. The woman has to lie flat for an extended period of time. It's obviously more expensive. We didn't do a cost-benefit analysis. That's something to do next. But for the protocol that we used for the screening MRI, it's a full diagnostic protocol. That is an expensive test. I think to use MRI only in the future, abbreviated MRI protocols or shorter screening protocols would be needed to make it a better cost benefit.
Great. Yeah, I think that brings up a good point because some of these limited sequence breast MRIs have gadolinium, some of them don't, and one of the concerns that has been raised recently is when we use contrast. Gadolinium in particular, you get gadolinium deposition in the brain, we now know. And so what about that concern, using contrast repeatedly in these relatively young women who are undergoing screening?
Yeah, that when we did this study hadn't really made it as a big concern in the general newspapers and a public concern, and it's not something that we actually investigated, but since having performed this study and definitely since moving home to Australia, it's something that the high-risk women that we definitely screen in Australia are concerned about, and we do experience women dropping out of MRI screening. First of all, they request, can we do the screening without gadolinium? Usually we feel that's an incomplete examination. Obviously, people looking at diffusion are trying to develop non-IV gadolinium MRI protocols, but they're not available yet. But yeah, it is a consumer concern, and it's something we will have to address.
In your study, there were no MR occult lesions. Can you comment on what types of lesions MR is picking up that mammography is not?
Yeah, so 2 of the cancers were MRI occult. So for MRI only detected 43 of the 45 cancers. One of the cancers was a 5 millimeter, I think, I have to check the number, cancer that was incidentally detected at a prophylactic mastectomy after having had the negative MR. And then the other occult cancer was a serendipitously biopsied cancer that was adjacent to a benign calcifying process. And the mammography had recalled the calcifications. The lesion with calcification wasn't cancer, but in the biopsy sample, a small cancer was found next to it. In terms of what type of cancers the MRI had detected that the mammography hadn't, it was both DCIS and invasive. So I think that's particularly interesting. People usually consider that mammography would detect calcifications representing DCIS that might be MRI occult. But of our DCIS 12 cases, mammography only detected one of those 12, and that was calcifications. MRI detected all the other ones, and that included up to 7 centimetres of DCIS. So it's not like it's a focal small non-mass enhancement. This was extensive DCIS that wasn't seen in mammography that MRI did detect. So it was both invasive and DCIS. But in terms of the numbers, MRI detected, compared to mammography, smaller cancers, more node negative cancers, and I think, I forget what the grades were, but it was getting, a better screening test because it's detecting cancers earlier.
Great. One of the questions we always have when breast MRI is used for screening is the recall rate and the concern of increasing the anxiety of women and bringing a lot of women back for more diagnostic tests. You actually had a recall rate of 23%, and in a screening population, that would be quite high. What do you recommend we do in the future to lower that rate?
Yeah, I think what's important to stress is that this was a retrospective study based from 2012 to 2014. So this is when the screening MRI reading was still relatively junior in the department, I think, and they've definitely changed the reading practices since I was a fellow there. We included BI-RADS-3 as a positive screening test. So part of that really high recall rate was the fact that we had, I think 10% of MRI studies were BI-RADS-3 read. So the radiologist thought it was probably benign, but worth some early interval follow-up imaging, whether that was another MRI or a second look ultrasound, and then if that was negative, to go back to screening. With experience, so this included both prevalent and incident rounds. With experience and actually doing, this retrospective study, we recognise cases that we can actually probably just say these are actually probably benign, call them negative from the get-go and improve that. So we do need to actually follow up and see how our practice has changed.
In your study, the exams weren't blinded to the reader. In other words, if the patient had a mammogram earlier, they had access to that when interpreting the MR. Do you have any data suggesting which test was most often first and how that could affect the performance of the interpretation and the other test?
Yep. So we didn't actually collect that data, unfortunately, so I can't give you the exact numbers. But what I can, explain is that if the cancer was visible at mammography and MRI, then both tests would have been positive. Consequently, also, if the MRI was performed first and the mammogram was read out after the MRI had been reported, or if it was by the same radiologist, that the mammogram probably would have, a subtle mammographic finding would have been read as positive given the definite MRI finding, yet we didn't really see that in the number of positive mammograms. So I think that this is a clinical practice study and it reflects real life screening. It's how it happens. Women might be scheduled for an MRI over the weekend on a Saturday and then come in on a Monday for their mammogram. The studies might not be read by the same radiologist. It's usually a chase to get to the MRIs on a Monday morning, so different people might have picked them up. It's a potential confounder and it's a limitation of a retrospective study, but I think it would probably have equally helped the sensitivity of both studies.
So one thing I was thinking about, and this gets back to something we were earlier speaking about, the cost of doing MRI screening and would you be able to drop the mammography, is that the BRCA women were obviously the highest risk group. They comprised 8.4% of your population, but they also had over half of the cancers. And so one of the things I was thinking is that since they're known to be such high-risk women, should we be considering them completely separately from the other high-risk groups in your study when we're talking about potential policy changes of switching MR screening to replace some aspects of mammography screening?
Yeah, I think that would probably be the group to start, given that mammography is less sensitive in that group already. And our population is a heterogeneous group, so it would be useful to pick the group of women that are going to benefit most from MRI and benefit least from mammography, to drop the mammography, because obviously it's the safer group to go with. My personal thought would be to go to biennial screening, or perhaps do single view, and that's because I've moved home to Australia, where our screening mammography for the general population is biennial anyway. So I'm actually used to having a 2-year mammography screening interval in a general population. Our high-risk women have the same. We do annual MRI and annual mammography. I think it'd be useful to pick your population, start with them, and maybe be driven by what they want. They're usually young women. They usually don't want to have too much radiation if they can avoid it, and if given the choice, the consumer might drive that. So you can see what they want.
You mentioned some differences in Australia compared to North America, and you have this interesting experience spanning the different continents. How is breast imaging handled in Australia that's different from Canada and the United States?
So our general population breast cancer screening is age 50 to 74 and every 2 years, and it's free. The government pays for it. Women can self-present from age 40 onwards, but we only screen every 2 years. So the mammography, that does help us to detect changes, because obviously there's a longer time to see a change between mammograms. For the high-risk population, we do have similar screening protocols of annual mammography with adjunctive MRI. However, our government funding only pays from age 30 to age 50. So it then becomes up to the woman to choose whether she privately wants to pay for that to continue with MRI screening beyond age 50. Currently, where I work in the tertiary hospital centres that I work at, we do offer tomosynthesis and then sometimes adjunctive screening ultrasound, whether or not you that's actually evidence-based, given that we might have more false positives. It might be a less sensitive screening test in that population. But it is certainly different. In North America, in Toronto, it's annual screening with both modalities, and they continue that.
Terrific. Well, thank you so much for taking the time to speak with us today. I really appreciate your time, and I love your study.
Cool. Thank you very much.